I'd say it's one of the most important things I've learned throughout my career in medicine so far, and that is oftentimes the most important thing we could do for the patient has nothing to do with medicine.
The reason I'm really excited to have you on this episode is because you're still considering, doing hemonc, and that wasn't really your route initially, and you had some, just like myself, which is what brought me into cancer, a couple of experiences in residency that really kind of opened your eyes. You have this big gig lined up, in Boston, and I'm super excited for you, a Harvard-affiliated institution, which I think is just such a good fit for what you do. Two of the cases we talked about had to pertain with central nervous tumors or head tumors. And this is a really confusing topic because a lot of people group them all together, but the truth is they're totally different and crazy. You had a pediatric case that was a neuroblastoma. So people that don't know, neuroblastomas are tumors that originate from like the original cells of the brain. So it's something that's like in embryo and then they get some mutations, and that's why you see it really early on, usually in pediatrics, versus things that are gliomas, and those are like the adult cells. Gliomas mean like it's not dividing anymore, right? So when kids like have trauma to the central nervous system or brain stuff, they recover because they're still kind of growing them to 5 years old. Whereas when you're older, obviously that's really bad news, hard to recover from a stroke, etc. And that's the glioma category. So tell me, how old? Let's start with the pediatric case of neuroblastoma. How old were they, and what really moved you about it?
Yeah, so they were actually, I would say a little more rare or maybe on that high risk category, but they were about 8 years old. So a little older than,
Oh,
sometimes we could see neuroblastoma, and that could be, worse off prognosis most generally. But I would say what really moved me, literally the cutest kid in the world, right? And so I was starting my pediatric oncology rotation because I'm crazy interested in hematology oncology, and I was in fourth year of medical school. And so when I meet this child, bald, going through chemo, literally, something that I couldn't imagine at the age I am, let alone being 8 years old. And I go up to this kid, expecting a kid to be withdrawn, like depressed, upset. Yeah, and I go and introduce myself to this adorable 8-year-old, and the kiddo said, "Well, Dr. Tommy, I bet you can't dance like me." Like right after I introduced
get
myself.
out of here.
Yeah. Yeah,
That's
it was
incredible.
it was insane. Like literally infusion going into this kiddo's arm and just like on top of the world. Like I'm new to this clinic, don't know everybody, but this kiddo is telling me to dance in front of all these nurses, all these other doctors that I obviously want to impress being a fourth year medical student. And now I don't even know how to dance, let alone. But she starts just like breaking it out and dancing along. And then she looks at me, "All right, Dr. Martin, it's your turn." She called me Dr. Tommy. "All right, Dr. Tommy, it's your turn." And so
No
obviously,
way.
yeah,
I love that.
for sure that that little kiddo taught me more about life than I think that I ever could learn from a textbook or from medicine or through medical school or anything. And my first couple of days there, I was so high strung and wanting to make a good impression, being very professional and doing hopefully doing all these things right. And then this little 8-year-old kid just humbles me and brings me to dancing in front of a bunch of people that I didn't know and I've never even danced before, and worried
Yeah.
about whether it was going to be professional or not. But she was like, "Look, the hardest thing that probably anybody could ever go through, and all I see is sunshine and rainbows, and I'm going to dance like nothing in the world's happening." And so, I had nothing to compare to that, and so I had to dance with her.
Yeah. And so that inspired you to consider hematology oncology, which I'll be honest, I respect that a lot because as much as I said everything I just said about making them the best version of themselves, my ward in residency was on the hemonc floor was next to the pediatric floor. So we would see patients getting chemo, same thing, like, hair loss and everything. And I can tell you, and I say this, humbly, like, not humbly, but honestly, earnestly, is that I couldn't even still, like, it hurt me so much to be able to see that, and that I think that's a sense of weakness because really I think it's a ethical and just a thing to come and be able to support people for challenges in their life. For people that don't know, childhood cancers, pediatrics, about 85% get cured, like at least with their cancers, which is vastly different from adults. And there's a couple of theories for this or observations. One, the organs and everything are very resilient, so you have to hit a tumor hard with cancer if you're trying to cure it. But at the same time, your body has to be able to handle it. And the organs of pediatric populations, they haven't either smoked or aged or gotten coronary artery disease and all this stuff, they're very hardy. So fortunately, the cure rate is very high. And then secondly, with neuroblastoma specifically, these things behave all crazy, right? Like you can have one that, literally self resorbs by itself, or you have one that all of a sudden accelerates, or you have one that turns, unfortunately into an aggressive cancer. On top of that, even if you have like the same kind of cancer, but somebody that's under 18 months old, even if it's spread, which has a really high mortality in my world in adults, it can actually be cured and is likely going to be cured with intense chemo. But even after 18 months, statistics drop off quite a bit. And I say all that just hoping people can appreciate that's the challenges of cancer. It's not even pegging the cancer. It's not even pegging the properties of the cancer. Then you're talking about even the age and all of these things. And we think part of it is because of how these cells still differentiate at the certain age you are meant to grow, so maybe it can overcome versus when they get rigid. And then when things get rigid, you're talking about glial cells. And all of a sudden you're talking about glioblastoma and all those, glial tumors in adults. And those are very difficult to treat, especially glioblastoma. And I hear, you had an experience personally with that as well. Can you tell us about that one?
Yeah, I definitely can. I was a resident at this time, and so in residency, I did a hematology oncology rotation again because I'm very interested in it. And I walked into this patient room. I already knew the diagnosis and everything, and the prognosis was very poor. And I walked in and introduced myself to this man, and he's an elderly man, and I say, hey, I'm Dr. Tommy Martin, very nice to meet you, I go by Tommy. He's like, you go by Tommy? Like, you should go by Dr. Martin. I'm like, okay, yeah, I can go by Dr. Martin. He's like, yeah, you don't need to go by Tommy, like, that's a kid's name. I'm like, okay, that's completely fine. And I was like, well, what do you like to go by? And he's like, I'm just going to use a name, but he's like, I go by Bob, but my friends call me Bobby, so you can call me Bob. I'm like, okay, Bob. Only his friends call him
As
Bob.
in, don't call me what my friends call me.
Yeah, essentially is what
Wow.
is what this patient was saying. So I do my exam, talk with him, talk with his wife a little bit for I don't know, probably 30 minutes or so, and then as I walk out of the room, I shake his hand and I'm like, Bobby, I'll see you tomorrow. And so at that time, he just like died laughing, because like he made it a point to be a little stern, to be a little rigid.
Right.
And then right before I was leaving the room, I called him by what only his friends are allowed to call him by, And
Oh, I love
so
that.
after that day, we became best friends. I would spend lots of time in his room every single day with him and his wife, really get to know him and, just like share experiences with him. And the, sorry.
Oh, no. Trust me, I understand.
And like I said, we became really, really good friends to where when he went home on hospice, they invited me into their home. And I got to spend time with him before his passing. And, it's one of the best experiences I've had in residency. And, like I'm tearing up, but the suffering that I'm experiencing is nothing that he went through. And he was able to battle it and go through it as an incredible husband. As an incredible dad and an incredible friend to me, and opened up to me and shared with me some of the most intimate parts of his life and trusted me enough with that. And it's an honor to call him, my friend.
Yeah, that's... Ugh, you got me tearing up. I was always very scientific and reasonable through most of my life about everything and rational, but I will say I have believed more in celestial orchestration, if you want to put it in that way, more since becoming an oncologist than ever before. And it's for things like this. Like, he served a purpose and role for you, but I have no doubt, like, you served one for him at a very stressful time. And you were this kind of bridge of medicine, patriarchal, you should not be Tommy, you should Dr. Martin, like what you need, classically from an oncologist or physician, to also being a bridge, like you're on the Venn diagram, you're in the middle, to also warm and kind and whatever. And that's, I think personally, and I know people disagree, but I think sometimes, especially with the end-of-life diagnosis as aggressive as GBM, I think that's what people need the most. They need friends, they need like a doctor, but if you can have someone that's kind of both, through a difficult time, it's extraordinary.
Yeah, I was just going to say one more thing on that I want all the listeners to know. I'd say it's one of the most important things I've learned throughout my career in medicine so far, and that is oftentimes the most important thing we could do for the patient has nothing to do with medicine. It could be a holding of a hand, or cooking of their favorite meal, or bringing them a iPad so they could Skype someone that they haven't seen in years before they pass. And so for all the listeners out there, like, we could do so many great things with medicine. We could, cure some cancers with medicine, and we could, save lives with medicine. But a lot of times the most meaningful, the most impactful, the thing that the patient's going to remember until their last second often has nothing to do with medicine at all. And it's what we do at the bedside with the patient and with their family members.
Yeah. I mean, I love that. It's not where you start and finish. It's like the journey along the way, right? And, I got tagged yesterday in a video by multiple people on TikTok, and it was a person basically saying, like, laughing. She's like, y'all get treatment, whatever. It's got to come back. You're going to die anyway. You have cancer. It was just very ugly. But then you see all the comments that were on there, like, well, one, a lot of people were hurt and upset because they were survivors, and this person was just saying like, you're just gonna come back, this and that. Why even go through all that? But the point is, and especially when if anyone says a lighter version of stage 4, if it's just palliative, you can't cure it. Why? I mean, I don't understand that question, because it's like, why wouldn't you want to like live if you have a decent quality of life? Like, it's so, when people say, look, well, you're gonna pass away, we all gonna pass. Like, that's a newsflash, right? Like, newsflash. So are you. So why like, I would never say that, but that's my thinking. And in palliative treatment now with targeted therapies, I mean, people are living years and years with no hair loss and like immune therapy and stuff. Sometimes it just like, crazy things happen. But to your point, it is very much about that. It's like, what have you done with the circumstances? And if people are happy, and I see it every day, they're happy, it's like, we should all just be kinder with each other and try to make our lives better and happier, because they're finite for all of us. You know what I mean?
For sure. And we actually didn't talk about this on the call beforehand either, but my grandmother passed away of cancer, of lung cancer, stage 4 lung cancer.
Right.
And I would be lying if I didn't say, like, well, Grandma, why not just stop? Like, why not just, like, don't go through this suffering. I don't want to see you suffer. And a lot of times I think that's, like, for me, like, I don't want to hurt so bad watching you suffer. Like, so why are you going to put yourself through this? But she wanted to see me graduate college. She wanted to see my sister get married. And so all of that suffering and hell that she was going through, like, all of that was worth it to see those things. So who are we to say not to let them go through it when their hope is in something that they may just want to see, that like they're willing to suffer, they're willing to go through this just for the reward of seeing those things.
Yeah, I mean, I'm so glad you said that, because I think my hardest challenge in practice is asking the patient, or making sure the patient speaks up in front of their family members. Because a lot of times they say like, why, or don't do this, or they say do it, and like whatever. And whichever side you're on, it's like, to put pressure on somebody facing their own mortality in the near future, I don't think it's selfish conscientiously. I think it's just knowing better. And hopefully anyone that listens to this can say, wow, like, that's a very good point. Like, if I was faced with my mortality and I had XYZ, I would, it's really, you really want to respect that and see what somebody's goals and values are. And that's a big part of ideal oncology practice, which is being able to revisit the goals, right? That's always a kind of a metric. And yeah, I'm really just glad you shared that story. Unfortunately, and I'm sorry your, grandmother went through that, but treatments now, like with lung cancer, are, thank goodness, like a lot more forgiving for the most part, right? Like with immune therapy and everything like that. And we're doing the best we can. But at the end of the day, at that moment, with whatever's offered in the world, like, don't push somebody on, like, say, like, oh, you should do the best that's offered in the world today to stay alive or not. Like, that is just a position that only the person in that position can know. And to judge that, I think, is very, but I know I'm, like, biased, or, like, understand that better because I see it every day, right? Tommy, we really appreciate having you. Everyone can find him at Dr. Tommy Martin, Dr. Tommy Martin. And I just want to say, I think it's very apparent, and especially after this talk, that you really are, like, an aggregate of all of your experiences, both from, penmen, or like both from people like Bobby that you experienced, as well as the younger child, and I can't imagine what other vast, crazy collection, including your grandmother, and it just shows. And I think, I respect that a lot, I admire that a lot, and I think, we can all learn more by receiving more, and try to potentiate that and everything that we learn from people. So thank you so much for being here. Can't wait to see what you do. I hope everyone follows. They really need to, because you're very inspirational, and I appreciate you.
Well, thank you so much. I appreciate you a ton as well, and your friendship means the world, and having me on the podcast is incredible as well. So thank you for having me.
Of course. All right, my friend.